I loved the program. It was fantastic. It taught me a lot. I got to interact with colleagues from across the U.S. in different disciplines, and I learned a lot about other disciplinary approaches to some of the questions I'd been asking.
Oh, it was phenomenal. It's the gift that keeps on giving, to be quite honest.
It was spectacular.
Transformative.
Game-changing.
It was the most phenomenal experience that honestly just shaped my career.
Oh, I love the HSS program. And I think for me, because I didn't come right after I did my PhD, it was actually a moment in my career where I was trying to retool.
It was an incredible experience to join forces with like-minded folks from all over the country who really care about population health.
It was an amazing opportunity to work with really talented people and people with many different perspectives, and it's going to shape my research and my friendships for the rest of my life.
For my own trajectory, I think the program was revolutionary. I was trained as a social demographer, and the fact that I got to rub shoulders with social epidemiologists, economists who are really interested in causal inference got me thinking in all sorts of new ways, and I am entirely a different researcher because of it.
The importance of connecting with scholars who are open to transdisciplinary collaborations has been a game-changing experience for me and my scholarship.
I describe it to my peers as the Cinderella program because they really just sweep you off your feet and give you every opportunity to succeed and put you in a group with the most interesting, novel, pushing the envelope kind of thinkers. They're really integrating across levels of analysis, and I just found it to be really intellectually stimulating.
Health and Society Scholars is a research fellowship program funded by the Robert Wood Johnson Foundation that was designed to bring researchers together to work in an interdisciplinary fashion to advance the science of population health.
When I was at Robert Wood Johnson, and even prior to that, I understood that the determinants of health went way beyond getting good health care, that they had to do a lot with the social situation in which you were living, in which you were born, your educational status, your housing status, and that if we were to make the kinds of improvements in health that we needed to make as a nation, we need to understand more how that happened. And so that led to the creation of the Scholars Program to develop the intellectual firepower to help ultimately us understand pathways to better health.
If we look at the determinants of health, there are basically 5 arenas, domains, in which health is determined. Our genetic predispositions, the social circumstances into which we're born, the behavioral choices that we make, the physical environments in which we live, and the care that we receive. The dynamics within each of those domains is vitally important in shaping health prospects of individuals and of society, but even more important than what happens within those domains is what happens between them at their intersection. Life occurs at the busy intersections in which we exist, in which we live and walk and move. And what's fundamentally important for society to progress is to have people who understand the dynamics of those intersections. So our aim was to develop a generation of intellectual and program leaders who could help us not only understand what the dynamics were at those intersections, but could move us actively into a healthier society.
We needed to better understand how to integrate all of the different factors that influence how healthy people can be. The economic factors, the genetic, the biologic factors, and the social factors, along with what we typically think of as our healthcare system. And we realized that we needed to do that because we were spending now $3 trillion on healthcare, and yet we are far from the healthiest country in the world. We have great inequity in our healthcare system and in the health status. And solving these very complex problems really required a different kind of researcher than we saw commonly in our environment.
It's taking a group of young scholars who are quite expert in their own disciplines, who realize that they need a little bit more, both methodological expertise as well as ability to bring other disciplines in order to investigate the issues they think are important. They're committed to health, and they're committed to understanding the determinants of health, and in many instances how their evidence can change the environments in which people live or health policies that will help make the community more healthy.
The program established 6 interdisciplinary sites across the nation at Columbia, Harvard, the Universities of Michigan, Pennsylvania, Wisconsin, and the University of California at San Francisco in collaboration with Berkeley. The program faculty included preeminent leaders in population health science.
The idea was that our 6 sites would collaboratively design the Health and Society Scholars Program together with what we call the Technical Advisory Committee at that time and RWJF staff to hammer out what would be the design and how we would have some coherence across the sites, but also allow for some uniqueness around the sites.
The program was different from others in that it combined a cross-disciplinary activity, a group of settings that would work not only individually but as a team in promoting a program as a whole, and that would bring together scholars who came from many different disciplines and would together learn about one another's work as well as fresh approaches to health concerns.
Being a site director has been really fulfilling. Not only to mentor probably the smartest and most creative, most innovative young scholars, but to push our work further as well and to have a set of colleagues with whom we collaborate on an ongoing way.
The purpose of it was just so exciting, to finally have a program that thinks about the upstream determinants and actually the whole range of determinants of health.
It encourages the scholars and the faculty connected to the scholars to really think outside the box, think about how things that people don't usually think of as related to health might actually have important health implications. In addition to having its sort of scientific emphasis, it's also very interested in translation of evidence into actions, into policies or interventions, and so that's also a very unique aspect of the program.
This is a group of people who broadly come from social and behavioral science backgrounds, although not exclusively by any means, who have a view of doing scientific research that they know will advance the health of the population and being willing to step forward and sort of moving from the research they do to trying to put it into action and make a difference.
Population health is the science of the ways in which the multiple determinants of health combine to affect the health and longevity of individuals. And population health science provides the evidence base upon which we can form policy change and programs that will improve the health of all populations.
Population health takes seriously the notion that health occurs over the life course, it occurs over time, and that your health is really shaped by where you work, live, and play.
It is an approach to science that is heavily infused with a commitment to social justice.
Population health is this umbrella in which public health belongs. But the determinants of population health are bigger. So we have to embrace a lot of different sectors. So we think about completely embracing the educational sector, or transportation, or health and housing. We think of things that are much larger than the proximate drivers of public health to think about what are the drivers of population health.
Another key part of population health is that it looks at the distribution of health. So not just what's the average health in the population, but are the people at the very bottom, how are they doing? The people at the very top, how far away are they in terms of health from the people at the very bottom? Can we get them closer so that people can have health no matter what socioeconomic status they come from, what race they are, what marginalized groups they're part of, and things like that?
It's a perspective on health that has real merit and real purchase on the problems of reaching health solutions. A perspective on health looking at the population as a whole gives you an appreciation of causes of ill health that understanding from one person at a time can never produce. You understand how social conditions affect health, how behavioral choices of a whole population affect everyone's opportunity for health, how policies and regulations also influence the chances for individual health. So population perspective on health is a critical and long-standing need, and I think it is here to stay.
When seeing the research that the recent scholars are doing, I just see the boundaries continue to be pushed further and further.
I always come away from the annual meeting filled with hope. What can be more hopeful than exciting, brilliant young minds working on cutting-edge issues? And as we build this field, we fully expect that these are going to be the future leaders that help us build population health science.
My research is about several things. So I do environmental epidemiology using electronic health records. That takes into account where people live and the types of environmental exposures that they're getting. And so some things I've worked on include whether people living near large animal feeding operations are at risk for antibiotic-resistant infections. And then more recently, I've been looking at people living near fracking in Pennsylvania and birth outcomes.
My research was looking at the mortality toll of the U.S. obesity epidemic.
My research is on place and how place matters for health. I focus primarily on cardiovascular disease as many of its risk factors. So for example, we focus on Life Simple 7, which is focusing on things like diet and physical activity and smoking. Those kinds of things are highly structured by opportunities and access and resources. So I look at the ways in which place shapes health behaviors and other health factors that cause heart disease.
So I'm very interested in the determinants of health at older age. So I integrate demographic and epidemiologic perspectives to understand the life course determinants of being healthy and unhealthy in old age.
I do research on how the social environment affects health, mostly looking at socioeconomic status, education, and income, and how it relates to health outcomes.
I study how neighborhoods have changed since the height of the civil rights movement, so how racial segregation and class segregation have changed, and then the consequences of that on health and health outcomes for blacks and whites in the United States.
I study mortality selection, which is the problem that our measurements of inequality are understated because we only measure the people who live long enough to be counted.
My research, broadly speaking, focuses on racial and ethnic differences in physical and mental health, with a particular focus on comorbidity, especially the co-occurrence of physical and psychiatric health problems.
My research early on as a graduate student wasn't focused on the kind of traditional areas of what psychology would consider its turf, in a sense. What I was really interested in was taking many of the things that we've learned through psychological science about how people make decisions, both cognitively, how they think about them, as well as from the behavioral point of view. What are the things that people need to do to have a different experience in making choices about their care? And I was interested in taking that which we had learned from psychology, from behavioral science, and applying that to a problem in healthcare and advancing how we deliver care.
My research focused on bureaucratic collaboration, trying to understand when agencies would work together to share problems that cross boundaries.
The Center for Medicare and Medicaid Innovation was created by the Affordable Care Act to test innovative payment and service delivery models for Medicare and Medicaid beneficiaries. So what that means is that, particularly for our group, which is focused on prevention and population health, we are testing ways that through the healthcare insurance and delivery system, we can improve population health.
So my research applies the growing field of network science to try to understand gun violence in US cities. So what I try to do is use models that you would use in standard epidemiological research to treat gun violence like a contagious disease, not sort of metaphorically, but literally, how it gets transmitted from person to person, how it spreads within small networks, and then ultimately to see how we can leverage that information for violence prevention.
My research during the time and still is really on the intersection of communication, politics, and policy. I think a major conclusion I've reached in my research is that public health is inherently political.
One of the challenges of population health research is to understand and reveal the underlying health inequities that exist. Many of the scholars address this challenge in their research.
Race is a social construction, but it's a very powerful social construction. It has real effects. The social construction privileges certain groups on the basis of skin color, and it disadvantages other groups on the basis of skin color.
I did a psychophysiology laboratory study where I examined the effects of media-based racism on physiological, behavioral, and emotional responses in Black and white adults. So I was really interested in sort of pushing our assessment of racism forward in health settings. Predominantly, this research is focused on individual experiences with racial discrimination, so being called a name or being followed in the store or having a direct encounter with a police officer. So I was interested in thinking more broadly about potentially more pervasive and relatively abstract experiences that might emerge through cultural expression, so use of language and symbolism and images. So I focused specifically on the media. So seeing a white male dressed in blackface as Trayvon Martin for Halloween, for instance, is the type of cultural expression that I was interested in. Similarly, I was interested in use of language. So for instance, Pat Buchanan referring to the president as a drug dealer of welfare. So the use of racially coded language in media. What I was particularly interested in is whether those types of exposures through media actually trigger stress responses that could be problematic for health over time.
I've started doing a lot of work on perceptions of race, not only at the individual level, but at the neighborhood level. Issues around stigma are central to understanding group disparities, particularly racial disparities.
So what we're finding are some really interesting patterns where Blacks and whites seem to be reacting in very different ways to different types of content.
So in order to understand neighborhood inequality, we have to understand the decisions, not just of African Americans or other racial and ethnic minority groups. We have to understand the decisions of whites. Most of neighborhood inequality right now is explained by the decisions of whites to leave central city neighborhoods.
So whites seem to have a stronger cardiovascular reactivity response to very blatant content. So someone in blackface, someone using the N-word, for instance. Whereas Blacks have a stronger cardiovascular response to very subtle references to racism content in the media. Interestingly, Blacks and whites didn't differ in what they told us they were feeling after they'd seen this content. So their emotional responses didn't differ, but their physiological responses did.
Initially, when I was looking at what happens in a neighborhood that affects how kids perform in school or how kids perform on a standardized test, for instance, I was looking for mechanisms, and more I started to think about what exactly goes on in a very disadvantaged community. I started focusing on things like quality of the schools, but also other aspects of social life within a community, like the level of violence, for instance, and started to gather more and more evidence on how community violence affects kids in the classroom and how this kind of reinforces and then reproduces patterns of inequality across different neighborhoods. If you look at kids, one of whom took a test right after a homicide occurred down the street, the other took the same test right before that homicide, then their scores will vary dramatically. So we can really pinpoint the impact of each incident of violence and how it affects kids in the school. I teach a course in urban sociology, and I focus quite a bit on neighborhood inequality, and particularly racial inequality, and I always begin the course by asking the students, well, should a red-headed white guy from the suburbs be teaching this course? And it's fascinating. You get a whole bunch of responses.
There's some personal responsibility there and it's also, to assume that I should be the teacher and tell you about racism is a very passive way to engage with these types of social issues. It also assumes that I own something about racism and that I have the authority over racism and I have to, share that with you, which is just not the case. If anyone has authority over racism, it's white people, I'd say. So.
My research focused on asthma and the epidemiology of chronic respiratory disease more generally. looking at how new types of technology, digital health, might help us both understand the burden and management of the disease in communities and individual households, and then also to think about new ways in which we could use technology to help improve self-management and outcomes for patients and their families. In the U.S., prevalence of asthma and COPD has continued to increase over the last few decades, but there's really no great explanation for why this is happening. One of the things we're trying to do at Propeller is understand how exposures that might be causing symptoms are distributed across the community. So what can we learn about when, where, and among whom asthma and COPD are happening so that we can then apply that information to public health. So at the end of the program, we made the decision to try to build a commercial version of the system. We created a company with 2 other folks and took the technology off campus and began essentially creating the first commercial version that was finally cleared by FDA in 2012.
So Propeller Health has designed this sensor which fits on top of inhaled medications for asthma, COPD, and other respiratory disease. And so when an individual goes to use their medication, the sensor is able to collect the date and the time and the number of puffs, as well as a GPS location of use. So all of a sudden we have access to information on where and when and how frequently people are using their rescue medications for asthma, which really gives us a signal into when people are experiencing symptoms, attacks, and because we have the information on the time and the place, we're able to pull in all of the relevant environmental and neighborhood information that might be driving that rescue inhaler use.
We currently have about 35 commercial programs running with health plans and systems across the U.S. Each of those programs has between 50 and around 1,000 people in them. One of Propeller's most important programs is with the city of Louisville, Kentucky, and the Institute for Healthy Air, Water, and Soil. We've been working with them for a number of years to build a program in the Louisville Metro that gives residents of the city access to the Propeller technology at no cost.
So the process was, kind of the best of sort of citizen science, so a real community-based initiative where we worked across our entire city to get people excited and enrolled in an experiment, essentially. And we had several hundred people participating over 18 months, and we found clusters of asthma events using this Propeller technology. And for the first time, we could see asthma in our community as a more localized phenomena, not as a sort of citywide phenomena.
We know that there's a lot of variation in the geographic exposures that cause symptoms of asthma and respiratory disease, but until now we haven't had a database that taught us about where and when those were occurring. With the information captured by programs like the one we have in Louisville and elsewhere, we're really able to see for the first time this new perspective on the distribution of asthma symptoms and the exposures to things in the environment that cause symptoms to develop.
I couldn't be more impressed with Propeller because of their way that they continuously learn and improve as a company. We've been working quite some time together now, and I think they saw in our city an authentic desire to improve our population's health through better air quality and reducing asthma suffering. And they had a pure mission, and we said, hey, let's work together and figure it out and get better together. And that's what's taking place right now.
ይህች ልጅ ሰውየውን የገደለችው ራሷን ለመከላከል ስትል ነው።
ያንን ግን ፍርድ ቤቱ አያምንም።
The subject of my research was actually the public health uses of media. The focus really of the grant was trying to explore how we can use media to raise awareness about the social determinants of health. I had just been working on a documentary about HIV that followed my research as a physician and a medical anthropologist. It was looking at the disproportionate rates of HIV in the African American community, particularly looking at women. And we shot in New York during my residency, as well as in Ethiopia, where I was doing some research as well. So this documentary pieced together kind of a larger argument about why Black women were dying at an increasing rate.
I think this tough obstacle of culture is ready to be talked about and dealt with.
There were certain myths at the time, and they still actually persist, that the reason why Black women were dying at an increased rate was due to things like promiscuity, and actually the research showed that wasn't the case. There were a lot of other factors like trauma, violence, and literally their zip codes that was determining risk. So the film was a way of kind of resetting this discourse and trying to raise awareness about HIV risk in a very different way.
But I also got involved in policy because, what I walked away from my HHS time is there's two things that needs to happen if we're going to make an impact on social determinants. One, we have to change the narrative, and two, we need to work on those policies. So I started this film production company, and then I entered government right after, actually. And I've been working in the media and kind of policy space for the last 7 years. The second film is called Boufford, which is an Amharic word that means courage. It's about a very famous legal precedent-setting case, women's rights case in Ethiopia, where a 14-year-old girl was essentially abducted and raped as part of this larger tradition of kidnapping of child brides, and she ends up killing her abductor and standing trial and becoming the first woman to claim self-defense in a court of law and win. It really tells kind of how women in these communities bring change for themselves. It has a pretty robust impact campaign that explores kind of the role of gender equality and foreign policy. We actually just submitted over 140,000 signatures to the Ambassador Catherine Russell last week at the Department of State as part of the impact campaign, asking the U.S. government to really release this adolescent girl strategy, which is focused on this issue of child marriage. The Sustainable Development Goals got announced, and actually child marriage is a target now. They want to end it by 2030. So this film and all the impact work with it has been tremendous. So what it afforded me was really time and resources to think out of the box and take the risk, and had I not, I would have never ended up doing what I am now.
When I started the program, I was a practicing pediatrician and had a public health degree, but was really interested in social determinants of health, but didn't exactly know where I was going with that. And as a result of the program, I ended up pursuing the academic route, but my relationships I developed and the network I developed through the program helped me start my work with the Federal Reserve Bank system, which led to my new project, which is the Build Healthy Places Network. Our mission is to support and catalyze work at the intersection of community development and health. So this is nonprofit community development that invests in low-income communities, trying to make them better, safer places to live. Minneapolis, Dallas, Cleveland, San Francisco. But we also are now really actively creating a website that is going to support people looking into doing this kind of work. So there's a whole network of people in this community development sector, this nonprofit sector, that are investing in neighborhoods, but they often don't know anybody in the health sector. They also don't know one another in many cases, so we're really the connector. So the community development sector has about $200 billion a year that they invest in low-income communities. And my experience is that people in public health and medicine don't know anything about them at all. And they have not traditionally measured health as an outcome of their work. So the way we've framed it is that they're leaving a return on investment unmeasured. And that really gets their attention because they see value in that. So what we'd like to do is basically nudge that $200 billion a year into work that's more closely aligned with the upstream social determinants that we're all interested in. One of the organizations I work with is called Purpose-Built Communities. It's based in Atlanta, Georgia. I started out working with a neighborhood called Eastlake, which is one of the most notorious neighborhoods in Atlanta. It was called Little Vietnam, not because there was a Vietnamese population, but because it was a war zone. And over the last 15-ish years, they have transformed it into a mixed income, so middle class and low income families. They redid all the housing in the neighborhood. They changed the schools, and the employment has gone up. Crime rate has plummeted. The kids are doing really well. And this organization, Purpose-Built Communities, is now working with 12 sites across the country now. And they did not consider health as one of their interests until we got a chance to talk to them, and they saw that everything they do has health implications for the children and families. I'd say that the population health focus changed my research much more dramatically towards the social determinants of health and away from my medical background. And so I really now believe, as a physician, that the most critical long-term factor for health is education. So completely outside of my medical background. So children being educated, especially through high school, just are going to have the opportunity to live much longer, healthier lives. And so that is sometimes difficult for me to share with my medical colleagues who are focused on treating illness, which is very, very important. But in order to keep kids out of the hospital long-term or out of the clinic long-term, you need to be well educated.
We're proud of the scholars, immensely proud of what all these cohorts have accomplished. We expect great things from them, and we will draw on them in many ways as we go forward.
We wouldn't have the audacity to think about building a culture of health if it weren't for the kind of work that we've had the privilege of doing with you, the Health and Society Scholars Program. So thank you.
Coming in as an ecologist with my previous notions of public health, I've been able to be exposed to a much more comprehensive view of what population health could be. So I feel really lucky to have been part of this community.
It really has been an incredible experience and hopefully prepared me to take what I've learned in graduate school as a policy advocate beforehand and go out and do research that will really benefit communities and benefit population health. And I'm very grateful for the support and the experience.
Although it's somewhat bittersweet that the program will come to a close, it's also spawned a new society. It'll have almost 200 alumni strong, and I have no doubt that they will continue to carry the torch.
Well, I feel very good about the HSS program because it's trained a cadre of scholars who will generate knowledge to understand how population issues affect our health and hopefully make us get a health record that we'll be proud of.
I hope that there will be a lot more opportunities for people trained this way to work in many different areas. In academia or in the private sector, in government, nonprofits, because we need people who think this way to really make a difference in health.
One person said, in talking about what the program has meant to her, that she has found her tribe. She has found her community. And so that's what I would say too, that this is my community as well. What the program has done for me, it has validated me, if you will, in terms of, well, yeah, so I'm not so different after all. There are other people out there who want to do this kind of work in the way that I want to do it. And so it's been wonderful in that way, yes.
Cinderella is not just a funny term I use for it. I truly do feel that they believe in you and say you are something special, and we are going to make sure you can do the research you want to do.
I think you could say that Robert Wood Johnson Foundation was really more than a funder of the program. It was part of what made it work. It was part of what nurtured it, part of what made it what it was.
The Robert Wood Johnson Foundation is incredibly grateful to the many people who made this program a success, from the site directors to the scholars themselves and the faculty, to the National Advisory Committee, to distinguished guests who have come to speak at the meetings, and of course to our National Program Office co-directors and staff. This program would never have been the brilliant success that it is if not for them.
The success of the program is not simply in the years it was actively operating, but in the work and the ongoing contributions that those who experience the program will be able to offer into the future. Of course, that applies to the fellows, but I believe it also applies to the faculty who had the experience of participating in this program. And it certainly applies to those of us who were privileged to serve on the advisory board. We were, in our own ways, changed and enlarged by the experience of this program. And I believe it was a very worthwhile investment over time. I think it will pay continued dividends over time.
HSS gives me hope because we have now trained a number of cohorts of people who totally understand the ways in which health is produced, the ways in which social and economic conditions produce health over a lifetime. And none of those people are giving up. They're energized, they're out there, they're well trained, and they will continue to do the work, I think, long after the program ends.